without starting the recording. So let me do that. And turn it to you. Yeah, and you can go ahead and share your slides.
Sure.
Looks perfect.
Good. Well, good afternoon, everybody, and I'm so glad it's been an honor to be part of this grand rounds as well. And I was last on campus pre-COVID about 5 years ago and spent a couple of days there. It was a joy to come back and can see the growth and to really visit and get a good feel for that. But I also appreciate the fact that we can do this virtually as well. So again, thank you again to the Planning Committee, Dr. Armstrong, for giving the opportunity and planning this out. And I'm really excited to talk about what I believe is a real important topic. You know, how do we emerge as equity-centered institutions? And basically, what would be that next generation of work we got to think about for DEI, for medical educators and leaders in medicine, because I believe that's where the effective and transformative changes that we need to move forward. So today, what I want to talk about is, you know, I'm going to have you reflect and think about and examine the institutional departmental landscape that you live in. As I go through people's lived experiences and what the data shows us about our learning and workplace environments, what I want you to think about as I go through this is, how does this resonate with you? How does it depict your own lived experiences, you know, at Emory and during your time, even when you're in other facilities that are associated with Emory and your particular education and training as well. And then secondly, I want to move into, you know, how do we set this up with regards to equity-centered learning and in workplace environments? What does that look like? And how does the practice of conscious inclusion, but also the practice of equity-mindedness can really help us create that vision for achieving an environment that essentially is not toxic and not hostile, but essentially allows us to thrive with the talent potential that we have. And number three, really discuss about, how does leadership play in this role? How does institutional investment play out? And more importantly than anything else, how do we hold medical educators or leadership in our institutions accountable so that we can achieve this next generation of DEI work? And then if we have time, I'm really interested to really just explore from you about, what do you think the role of the Department of Medicine can play and the contributions that you can make as a department in helping the School of Medicine really achieve this next generation of work, because that's what's really going to matter more than anything else when I walk away. So I'm going to start with a picture, basically because I think pictures are worth 1,000 words, just to make this one point, and I'll give you a little bit of time to look at these. And I think you'd agree with me that our learning and our workplace environments within our academic, medical, and health science centers are really microcosms of society. You know, the walls of our centers basically do not keep out the sentinel events that happen around us in society, but especially also the impact that these particular events have, you know, on our worldview, our belief systems as they get challenged, our cultural identity, and even our emotions. And it's sometimes difficult for some of us to block that out, even when we're in the classroom teaching, in the classroom observing, or even when we're at our workplace as well. Clearly, the number of challenges that our campuses, our hospitals, and our societies have been facing over the past number of years, and the challenges continue to persist that these particular pictures dictate, you know, are quite overwhelming. And that's probably an understatement that is there. In the political social climate, the racial divide, the political divide that's going on in our country, we've all experienced it in one way or another as it impacted us individually, our families, or even the community that we have come from. And the things that I've observed as well, I'm sure you have as well, is that it's created a lot of anxiety, a lot of stress, a lot of tension, but even frustration, and expressed concerns for a lot of our medical educators, our administrative teams, but also for our offices of diversity, equity, and inclusion that basically has been in the forefront of this particular fight and continues to be there as well. There's no question that the COVID-19 pandemic and the racial reckoning that has occurred has really had a major impact on the health and the mental health of our staff, our learners, but especially a call out to our faculty and our residents who are on the front line that really face these new challenges that no one could have ever anticipated when the pandemic hit. And the pandemic's not over. We don't even know it. We have an uncertainty about us of not even knowing what the next surge is going to be and what and how is it going to impact us, and are we prepared for that? But some of these challenges certainly resulted, especially in our faculty, what I've been noticing is of feelings of frustration, overwhelming fatigue, hopelessness, loss of control, and in some cases, burnout. And I've also begun to see that also in the residents and fellows to also include them as well. But this in turn has really impacted our learners because of the decreased presence of who their teachers are, our residents, our faculties, and our fellows who serve as role models and mentors, and even those particular faculties' involvement in some of the key committees that a lot of our BIPOC faculty were part of, including admissions committees, including learning committees, and including our student progress committees as well. Because now they become invisible because of the other unanticipated workloads that they have as well. There's been a lot of racial tension experienced by our BIPOC staff, faculty, medical students, residents, and fellows, and even in their families and communities, and some of the experience either directly or indirectly. So it's difficult for most of us, I find, to really talk about this, but I think it's a real critical time to do a more careful examination of our educational and our workplace environments. I feel that we have an obligation as medical educators and administrators to really explore, to listen to, and to try to understand the many lived experiences that our students, residents, faculty, and staff have been facing, and how it has impacted them mentally and physically. And so what are some of those lived experiences? Our literature basically has documented extremely well over the last 20 years those challenges that our graduate students, our medical students, residents, and faculty from historically excluded and unrepresented groups in STEM have been facing. And they're depicted here on this particular slide. I've already talked a little bit about the lack of exposure to our BIPOC faculty, our science and healthcare providers who serve as role models and mentors due to the unanticipated workloads that they've had. But also I want to call out the fact that the importance of cultural identity, especially in our students and faculty. And some that remain their social identities as well are being questioned, in our institutions, but they're also being devalued. There's this expectation that we all assimilate to the culture of medicine and science, and not realizing the difficulty it is for some of our students, faculty, and staff to be able to do that wholly and to fully assimilate, maybe acculturate, but not assimilate. The other part on the right-hand side of the screen, you'll see, again, the common things that we do see that challenges them every day, the daily and chronic microaggressions that occur, the stereotype threat, depending on the context of where people are entering into, the daily racial biases, prejudice, and discrimination, not only just from colleagues and peers, but now also from our patients and even their families and visitors, and I'll talk about that in a second. And then the coping behaviors that we have taken on in order to deal with some of these as well, such as racial battle fatigue, identity interference, code switching. The burden of minority tax is not just on faculty, but it's also on students as well. And subsequent, the rise and the increase in continued mistreatment events, and also the sexual and gender harassment is at an all-time high. That leads to some abnormal coping behaviors, such as isolation and marginalization as well, thing that we should be really concerned about. Our literature also had developed papers that have been written by our faculty sharing their lived experiences within the academy. This is just one of many that are out there. It was published in the Annual of Family Medicine by 10 different faculty members in Family Med and Department of Family Medicines. And this is what they said. It's just a snapshot of what they say in this particular article that is so important, I think, for us to read. And that is, quote, "We are tired. Those of us who have been championing anti-racism and justice work and bearing the burden of the minority tax have been overwhelmed. I ask for my well-intentioned white colleagues. Please hear our story and heed our call." We've heard really similar kind of accounts from, especially when we've had held town halls with our AAMC group on diversity and inclusion faculty with what academic medicine can do during these particular times. And I think these two quotes that I'm going to read to you right now are just themes from the many responses that we have received, but I think they're captured very well and send a message that I think is really important. The first one saying, we need your help in affirming that our experience as Black faculty, no matter how egregious and unbelievable they may seem, are honest and real. We need your help in calling out institutions that continue to write statements of solidarity while not changing the toxic hostility and anti-Blackness within their culture. This is not just for Black faculty as well. You could fill in the blank with the many different multicultural faculty that we have, but also others with other different identities that play out in almost exactly the same way due to the learning and workplace environment in which they operate on. The second quote is also very important. And again, in the same way, you could substitute who that faculty member is, their particular identity. So as a Black woman in medicine, I'm at great risk for harm when I try to lead my community in a discourse around racism, and for that matter, for any other ism. We need to train our non-Black, non-Indigenous, non-Latinx people to do this work and to do it well. They cannot shirk from the emotional pain and the tremendous personal toll that it takes. In addition to that, we know that burnout was beginning to rise. And this is actually pre-COVID. This was published in 2019 by colleagues at the AAMC. Valerie Dander and her group basically looked at and took a sample from 13 institutions made up of over 7,600 faculty members that responded between January 2016 and September 2018. The importance about this, basically, look on the right-hand side, just to go over that legend a little bit. This is depicted by different domains, the top domain being by department type. The second domain that you see there is by rank, and the bottom domain is by race and ethnicity, race and gender, I'm sorry. The green represents those that basically have said, we enjoy work. The yellow depicts under those that are under immense stress. The brown or the mahogany colored one is those that are having burnout symptoms already. And the ones in the dark brown basically represent those that are already burned out. We find that overall that 29% of our faculty, this is pre-COVID now, are burning out or have been burned out. The majority of those, 31% of those, was in those that were doing, patient care. The basic science faculty, again, playing about 26% of our basic science faculty, were also burning out as well. The interesting thing, when you disaggregated the data by gender, we found that the women faculty, both underrepresented in medicine faculty, women faculty, but also non-URM women faculty, also reported more burnout than their men colleagues as well. 35% of URM women faculty and 35% of non-URM faculty reported burnout. And then as the self-reported levels of burnout increased among faculty, we found that the satisfaction with their department and with their institution really decreased, and the intent to leave the institution or department increased as well. We're also well aware of the 2017 report from the National Academy of Medicine that began looking at wellness and resilience. And basically an unanticipated finding at that time was that among the most telling of statistics, that more than 50% of the US physicians reported symptoms of burnout at that time. This particular publication really made us look inside ourselves and really took a mirror of our institutions to realize the impact that our culture and climate has on physicians. And more of these, and this 50% was 2 times as prevalent among physicians in comparison to other US workers in any other fields, after even controlling for their work hours and other factors as well. And one of the key highlights for this, and this is why we're talking about culture and climate within our learning workplace environments, is that we found that one of the biggest causes for this, number one causes, was the culture and climate within the institution that we are in. The bottom of the screen, you'll see the work by Shanafelt and Noseworthy that also found out that burnout also contributes to other things, certainly broken relationships, alcohol and substance abuse, increasing depression, and incidences of suicide were high. And in fact, NASM found that 400 physicians die by suicide each year, which is a rate that's more than twice that of the general population. But Shanafelt and Noseworthy also found that burnout contributes to a decreased quality of care that's provided, that puts patient safety at risk. There's been an increase in medical errors associated with it, decrease in patient satisfaction, decrease in productivity by the physicians, and also the professional effort, and then also attributing to attrition and physician turnover as well. A recent study that was published in the Mayo Clinical Proceedings, it looked at, how has COVID affected this, and what are the intentions, in the workplace. And they found that 1 in 5 physicians and 2 in 5 nurses intend to leave their practice within 2 years. In academic medicine, we talk about the great resignation of our faculty as well, which kind of falls out, and it's very much in alignment with what we're seeing here too. They also found that 1 in 3 physicians, advanced practitioners as well, and nurses intend to reduce their hours in the next 12 months. So we do have some significant challenges before. Derby and colleagues also talked about, you heard me talk a little bit about the mistreatment and discrimination prejudices by now a new player in the act, and that is our patients and their visitors and their families. So Derby looked at, did a cross-sectional survey of looking at, and there was over 6,500 U.S. physicians that responded to this from November 20th to about March 2021. I'm sorry, November 2020 to March 2021, had a really high response rate here. Overall, what she and her colleagues have found is that about 28.7% of the physicians were subjected to offensive sexist remarks. 20.5% were subjected to unsexual advances. 29.4% were subjected to racially or ethically offensive remarks as well. And about 21.5% were subjected to patients or families that refused to allow them to provide care for them due to their physician's attributes, meaning their race, ethnicity, their gender. And more interesting, when the data was disaggregated by race, ethnicity, and gender, there were significant differences that were seen that are depicted by this slide. Pulled out of their tables, I wanted to make it a little bit more clear and easier to read here. But it's pretty clear that essentially when you begin looking at these numbers is that, a high percentage of women physicians and Black physicians basically were victims of offensive racial, ethical remarks. The highest actually being in Asian American Pacific Islander women at 59.3%, and the highest being in Black men at about 57.1%. When you look at the comparison, there's not really much differences about who is a victim of these offensive racial ethnic remarks. When we look at offensive sexist remarks, we find that women were subjected to a much higher percentage of offensive sexist remarks and also unwanted sexual advances. And we'll see another slide that will depict this as well. But a high propensity of this, we found that white women received the highest amount of offensive sexist remarks, and Black women received the most amount of unwanted sexual advances in our hospital settings as well. And then last, but looking at the patient refusal of care, we found that essentially that, again, higher than normal percentage that we would have expected of people refusing care if you were Black, Asian American, Latino. LHS stands for Latino and Hispanic and other Spanish heritage, and then white women. We found that the Black women and Black men were the highest with regards to whose refusal of care based on their physician attributes as well. This is just a graph of looking at some of the Maslow burnout inventory scales that they use on high emotional exhaustion, high depersonalization, and also burnout. And when you look at the racial, when they looked at the racial and ethically offensive remarks, this is what they found. And they found the bottom axis, you'll see, on the x-axis, you'll see the frequency of these types of experiences or events. The y-axis has the percentage of number of respondents. And what you found is that as the frequency of being subjected to racially and ethically offensive remarks increased from never on the very far left to several times a week on the far right, they observed that there was an increase in the percentage of participants with high emotional exhaustion, those are the dark blue bars, high depersonalization, those are the blue bars in the middle, and then burnout, which are the light blue bars as well. And similarly, we see that same type of pattern when they were subjected to patients or families refusing to allow them care, where essentially the frequency of depersonalization, high emotional exhaustion, and burnout, rose along with that. And we saw very similarly the frequency being subjected to offensive sexist remarks and unwanted sexual advances increased from never to several times a week. They also observed an increase in the percentage of patients with high emotional exhaustion, high depersonalization, and burnout. And these all, by the way, have a significance of a p-value of less than 0.001. The importance about this, again, is I'm not going to concentrate on the graph on the right, but basically it's just kind of a summation of all the mistreatment and discrimination and the frequency, depicting the same sort of things that you showed in these other graphs. But more importantly is, why is this important? Why am I talking about this? And that is because the impact of mistreatment and discrimination has now been documented. We talked a lot about exhaustion and depersonalization, but now there's evidence coming out that more and more physicians, more and more of our faculty, more and more of our residents are also building self-doubt. That imposter syndrome is starting to come back and to haunt us as well. That feeling of invalidation, a feeling of isolation is coming back. And then abnormal coping behaviors like increasing cynicism, racial battle fatigue, as we talked about, is popping in. But we're also seeing that negative impact. There's a major negative impact on career advancement, attrition, and even career satisfaction as well. And again, residents aren't left out of this. As we begin moving upstream, we realize that, again, much of this, these challenges have existed earlier on, not just when you become faculty. So this is just a depiction of a systemic review that was done by Finesse and his colleagues back in about 2011, doing a systemic review of the literature, looking at the prevalence of harassment and also discrimination among medical students and residents. And today I'm just going to really kind of concentrate on this particular column here that represents harassment, the percentage of harassment. And overall, 63.4% of residents in 19 studies, that means over 11,000 residents, basically claimed that they experienced during their training, harassment. And then when you look down the disaggregated data, you found that gender discrimination was at 66.6% of being experienced. You'll see that sexual harassment at 36.2% and racial discrimination at 26.6%. Since that time, there's been an explosion of now the data that it's pretty clear that our particular environments do, unfortunately, have a rise in mistreatment and sexual and gender harassment. On the left-hand side, you see one that was published by Cheng from her institution, and overlooks at about 5 different residencies depicted here. As you say, there was over 105 residents that answered, and what they found is that 42% of the residents in all of these specialties collectively had witnessed mistreatment of a co-resident. 25% of them personally experienced mistreatment themselves, and 71% of those that were mistreated met burnout criteria. And for those who personally experienced mistreatment, they found that they were 8 times more likely to report burnout and 4 times more likely to report mental problems. Similarly, on the right-hand side, you'll see a larger study. Basically, it was published by Yu Young Hu in the New England Journal of Medicine, and did a national survey of all general surgery residency programs and looked at over 260 general surgery residency programs. And the sample size was over 7,400 surgical residents who were there. 30% reported verbal and physical abuse, 32% gender discrimination, 16% racial discrimination, and about 35% met the criteria for burnout, and 4.5% of those had suicidal thoughts. This is another study that recently also came out by de Bourmont and their colleagues as well, looking at the residents' experiences with and responses to biased patients. And so this is a retrospective survey that only looked at PGY2, and PGY3 residents as well. And the cited behaviors that they were looking at was belittling or demeaning stereotypes, role questioning, sexual harassment, explicit epithets or rejections of care as well. And what they found is basically nearly all the residents experienced or witnessed biased behavior. And more frightening was when the data was disaggregated by race, ethnicity, and gender. They found that women, Black or Latinx, and Asian residents reported experiencing more biased behavior more frequently than their white colleagues as well. On the left-hand side, this looks at, on the x-axis, has all the different behaviors On the y-axis is the participants that are there. The blue bar basically represents a combination of the Latino and the Black residents. The blue bar in the middle is our Asian Pacific Islanders, and then our light blue bar represents our white residents. It's kind of giving us a snapshot of what they experienced as well. What we found about when we look at explicit epithets or rejection of care, which is the third grouping on the left-hand side there, found that 45% of the African American, Black, and Latino students basically had a higher frequency rate of patients experiencing biased behavior from them and being called racial explicit epithets, and also had the rejection of care as well. 90% of the women experienced role questioning behaviors, as depicted on the slide as well, both sides. Again, we also find the African American and Asian American residents also experiencing a high prevalence of that. If you look on the right-hand side, is that 87% of the women experience sexual harassment. The interesting thing about the study that I also bring up with medical students is that when the residents were asked at the end of this particular survey, with this percentage, did you report the incident to your institution? The frightening statistics is that 85% said that they never reported their incident to their institution because of fearful of retribution and retaliation. This is the last thing I'll show you about the data, and this is our medical students as we continue to go upstream, and we find that this is the AAMC 2021 graduate questionnaire that all fourth-year medical students fill out before they graduate as well. And question number 42 specifically asks about, have you personally experienced any of the listed behaviors? And there's 17 mistreatment behaviors that are listed for the students. And what we found is that there hasn't been much change in that particular environment or the lived experiences over the last 6 years or so. In 2021, we found that 40.3% of our fourth-year graduating students personally experienced any of the listed behaviors. What's excluded from those behaviors being publicly humiliated or embarrassed. That's not included in this particular data. And this is in spite of when they asked about, were you aware of policies on mistreatment at your institution? And were you aware of the procedures? Over 97% of the students said, yes, we're aware of the policies. Over 89% said, yes, we're aware of the procedures. But in question, but only in question 45, when we asked, did you report the behavior, very similarly to how the residents responded in that last study I showed you, 72% did not report this particular behavior, even knowing the because this is about institutional culture and institutional climate. And this was just a summary on medical students, but every medical school, every institution has their own report card that they need to begin looking at as well. And again, I think the most important piece about this is that given these findings, and they're not wonderful findings to be talking about and looking at, but important to look at, because I really believe that we as faculty and administrators really have this obligation to pay better attention to the institutional environment and climate, and then really do make a fruitful effort to make systemic changes that will mitigate these challenges eventually. Why? And again, much like I showed you with the faculty, is the fact is that now we have many studies that are now showing the impact of mistreatment on our medical students and residents. We don't have to wait till they're faculty. The reality is that there's an increasing evidence of poor emotional and mental health outcomes. Substance and chemical abuse is very much alive. Decreased self-confidence and self-esteem, which impacts their performance as well, and also impacts patient safety, but also higher rates of depression and suicidal ideation in our medical students and residents. Post-traumatic stress disorder has also been described as well, and as well as burning out and symptoms of burnout as well. So after reviewing this particular and giving the lectures on this particular and going over this data too, it still stymies me, and it's difficult to talk about. But when I found this quote from Barbara Brown, it really resonated with me because there's a darkness aspect to what I just presented to you. And this quote from Barbara Brown, I thought really will resonate with, I hope it will resonate with you. Let me just take a few seconds to read this. I have learned things in the dark that I could never have learned in the light. Things that have saved my life over and over again, so that there is really only one logical conclusion. I need darkness as much as I need light, and new life starts in the dark. And it made me ask the question, where can we as medical educators and leaders in medicine go from here? What can we learn from this particular darkness? So at the time when I started thinking about this and looking at the data and pulling it together, at that same time, Representative John Lewis had passed away. But it really moved me after reading this darkness is to really channel him. As a reminder, remember, he was a civil rights legend who devoted his life to racial injustice and equality. I don't need to remind you of that, people from Atlanta. But one person that inspired him the most was Rosa Parks, as he talked about. And he said, she said that, she inspired us in a way to really get in the way, to get into what he called good trouble. He called necessary trouble. And he's quoted by saying, if you see something that's not right, that's not fair, and not just, do something. We cannot afford to be quiet. And never, ever be afraid to make some noise and to get into good trouble, necessary trouble. And so what I'm going to end with today with you is my hope that is, if anything you forget, you will remember this quote, because I think it's really important to drive us and to help us focus a little bit about what's really important today, especially. In his words, I think are just important today as they were back when he said them in July of 2020. How do we make good trouble? So what I'd like to do is, ask the question, what can we learn from the darkness? And how can we make good trouble? And I would like to suggest 3 things. So number 1, I want to start with, I think we need to have a change of mindset, and maybe even perhaps go back to our own beginning, the beginning of our journey when we were contemplating a health career and becoming a physician possibly, and maybe resurrect and practice again what we believed in then. We seem to have, some of us seem to have lost our way, and especially those that basically think that we're evoking a woke type, that medicine has become woke in a derogatory way. And maybe resurrect and practice what we believed in back then and bring it back to life now. So for me, the 3 elements that centered me at the beginning of my own personal journey that were really influenced by mentors were the 3 that you see here. Humbly serve others to be a good physician, get proximate with your patients, and also practice radical empathy. And I love this quote in the book From Just Mercy, A Story of Justice and Redemption by Brian Stevenson, that still sticks with me after I heard him speak at one of our LSL meetings. And the quote is this: we cannot create justice without getting close to the places where injustices prevail. We have to get proximate. And I would say get proximate not only with our patients, get proximate with our learners, with our peers, with the people that we care about. Because there is power when we get proximate, and only then can we have mercy and have compassion. And these 3 elements, I think, will assist us in affirming the narratives of others, like those 2 that I showed you, the 3 I showed you from faculty, that was very personal and very important for us to remember. I think we get tired, my faculty get really tired by people thinking that they're making these things up and it can't be quite as bad because I personally am not experiencing what you're seeing, sort of thing. I think it's really a critical time to us really to get back and to really affirm the lived experiences of others within the institution. And that's at all levels, not just faculty, but our learners, but even our staff who basically provide for us and care for and allow us to do the things that we do. And allow those particular lived experiences to drive the change that we really need. So I'll even ask you, what are the 3 elements that centered you at the beginning of your journey? Do you remember them? Do you practice them still today? What else can we do? And I think the second element that I want to leave with you today is, how do we disrupt? I really believe that we need to disrupt the status quo, to really change the narrative and do what we need to do in order to change that narrative, or better put in a different way, maybe how to provide a counterframe to the status quo, This really calls for a transformative change if we're really going to truly achieve, equity in our work and learning workspaces and racial justice as well. But I think the important piece about this is, what are some action items we can do? And one of them would be this equity-centered piece that I talked about at the very beginning. I look at the third dimension to achieve excellence, along with diversity and inclusion, is equity, not just health equity. And if I define it, this is what it looks like. Because sometimes you have to paint a picture or a graphic or a map of this, for people to really understand what are you talking about when you say this. And by definition, an equity-centered learning and workplace environment, they're achieved when every person in an organization or an institution is given that opportunity to attain their full potential. And no one is disadvantaged from attaining that potential, because of their multiple identities or their social positions. Likewise, I have the definition for racial justice because, again, it also speaks and is very much in alignment about what an equity-centered learning place is and a workplace is. And racial justice is the systematic fair treatment of people of all races. And I want to emphasize all races as well in this, that results in equitable opportunities and outcomes for everyone. So I think that's really important to remind us what truly racial justice is, because many people are turned off by that particular phrase and misinterpreting what that really means. It's this whole notion that all of us should be able to achieve our full potential, regardless of our identities and who we are in the space that we live in. And the opportunities are depicted on the left of your slide. It doesn't mean to represent every opportunity, but to give you an idea, what are those opportunities that we really talk about that I think are meaningful for everyone and not just a certain particular group. These are things such as personal development, professional development, access to opportunities, advancement, educational opportunities, salary equity, for example, and the list goes on and on. And what this is really about institutional investment. And it starts at the department level, but also by the institution as well. This investment in everyone that works in or is part of the department or the organizational community itself, including staff. So what does its environment look like if we were to draw a map of that and a picture of it? So the AAMC, when I got there in 2017, was lacking kind of this map. What does it look like? Because that was probably the most common question that we received. What does it look like when we get there, sort of thing? So we developed the foundational principles of inclusion excellence at that time in 2017. And basically it's a vision about how do you practice consciously, how do you practice conscious inclusion, and how do you get to inclusiveness, and also how do you practice equity mindedness, and what does that all mean? And so in an institution that has really achieved excellence, DEI is accepted. I mean, there's just not questioned anymore. It's part of the strategic imperative as much of any imperative you create in your strategic plan. It's intentional and it's embedded in all the operations that you do. But that happens because of the following, is that in an institution that has and the intersectionality of those authentic identities are valued and they're actually practiced fully. And that occurs because you have a safe or a brave environment in which you can actually be authentic as well and not feel you can share your voices openly and not feel that you can't because of fear of judgment or retribution. What also occurs is dignity consciousness is valued. That is, all of us are born with dignity and no one has the right to violate our dignity. But can you imagine an environment where, again, how could that impact and how will that impact people's respect for ourselves? But a dignity consciousness environment reveals that everyone feels validated, is made to feel validated for who they are, what they bring to the table. They're valued for their contributions and ultimately respected as well. Also, equity mindedness is also adopted at that time as well. This is a big part of the roadmap itself. And what that means in translation is what I've already said, is that this is that in the organizational investment that's really focused on patients' assets, and their potential. It's not focused like it is today. We focus on a lot of people's deficits of why they can't be in medicine or why they fail in medicine. What we're talking about is how do we basically dig into those golden nuggets what people bring from the table, from their lived experience, lived work experiences that we never tap, and we need to tap that. In other words, do talent optimization. The second piece of equity mindedness is to really look at exclusionary practices that may be embedded in our policies, our procedures, our governance, our operations, but even in our traditions and cultural norms. We today are not necessarily responsible for our ancestors of how they placed that and embedded it in our institutional policies and practices, but we have a responsibility of at least evaluating it, exploring it, and really looking for exclusionary practices are there. And if we identify them, how do we dismantle them? How do we deconstruct that so we can basically begin addressing that and using system-based solutions, using system-based thinking in order to arrive at some solutions to transform that status quo. And lastly, but not least, how do we build upon people's profession and career development and amplify those experiences so they can do this particular work? And overall, last but not least, what's most important is that we have an accountability system that's in place that holds everybody accountable for these particular DEI efforts, and I think will resonate with you too. So I think this is the vision, and that's the hope, that everybody would look at this from an agreement standpoint to really work towards achieving that particular state. Again, to get this transformational change, how do we do this? Because this seems pretty daunting, but I think we need different leaders. And I think the leaders that we need is learning how to become equity-centered leaders and medical educators. Equity-centered medical educators focus on evidence-based. They are equity advancing. They understand racial justice. They're system-based thinkers, and they're institutionally focused. And they recognize the persistent inequities that exist that are a result of our social and structural inequities in our educational system. And they understand as leaders that we have an obligation to begin addressing these inequities and the fallout that they create in our students, our faculty, and our staff as well. So these are really change agents, and they use this mindset in order to induce change. And to really drill down a little bit what this means, what the evidence-based means is that equity-centered leaders and medical educators, they study the data. They look at the social and historical context of structural oppression, experimentation, and experimental practices that have been in medicine for years that have also have had impact and have influenced our policies and infrastructure we have together as well. They acknowledge that past, they learn from the past, and they try to make reparation for it. Equity-centered leaders and medical educators are also equity advancing, where they reject this ingrained habit of blaming inequities and outcomes on faculty and leaders because of their background and where they came from. And the intersection of these, how important these intersections of identities are so important that it's not important just to have a science identity, but how does that interact with my cultural identity? As a Latino, speaking from my own words, this is the notion in which if we're equity advanced, we're really focusing and leveraging those assets, that talent potential as well. Number three, I think the important piece is that the focus on racial justice is important because this is about exploring how structural racism has been embedded in and influences our health professions education. But this is about intentionally addressing the entrenched biases, whether they're conscious or unconscious, the prevailing stereotypes that exist, and any form of discriminations are identified. There's a willingness to examine the infrastructure, the policies and procedures, as I mentioned prior to before, even our embedded norms and values that sustains these inequities that people think that are race neutral. The third element is being systems thinkers, and this is important and necessary for transformative changes to happen. And this is basically going to be needed in order to disrupt that status quo that I talked about. We need to shift the paradigm, because right now the paradigm is either weeding out, screen out, publish, or perish, to one and more of an investment model to really address the asset bundles that people have and work on that. And it's also lastly being institutional focus, meaning we are responsible for our institutional effectiveness for people's successes, and we need to be held accountable for that. This is about investing time, effort, and maybe even some political and social capital and risking it as well. It's about mobilizing efforts and bringing even our community to become community engaged, is invite our community in who experience us as an anchor institution to really help us define some of those solutions that we may not be thinking of, but they may have already had. And lastly, but not this, work really starts with our own assessment and asking some hard questions, such as, are exclusionary practices operating here? What are the manifestations of structural racism that are operating here as well? And the last element of this is about leadership and investment, because it does matter. And here are some constructive ideas we can think about this. David Scorton and I wrote a paper not too long ago in October of 2021. It got published in the American Journal of Medicine. If you haven't seen it or read it, I would really invite you to review it, because they'll go in a little bit more depth of what I'm talking about here. But I think this is about fighting for the things that we care about, as Ruth Bader Ginsburg said, but also do it in a way that will lead others. My hope is that with the things I'm talking about today, will basically influence other departments within the institution to begin thinking about this as well. And so from the start, number one, when I said leadership matters, some of the construction action steps that you as medical educators and as leaders can do is certainly start with use the power that you have, use the voice that you have and the privilege that comes with it in order to dismantle racism in medicine. This is about advocating for systematic changes in your department. That's where it's going to start. But also, hopefully, that will resonate and ripple out to the institution as a whole. Because Emory is a school of medicine and an anchor of institution, because Emory School of Medicine is an anchor institution, again, as I mentioned, think about engaging the local community to help you and as a partner in addressing and eliminating systemic racism and exclusionary practices. They may have some solutions that we may have not thought about. Number two, I think it's really important for our leaders and medical educators. If you don't have the skill sets for this, get the skill, be trained on how to have courageous conversations about privilege that have been built into the existing system and that benefits others, that benefits some but excludes many others. And the important piece about this is really discussing how privilege manifests at your institution or your department, where it's embedded inside your policies and problems that preserves the status quo that's there, and then address how to critically deconstruct that privilege, not get rid of it, but deconstruct it in such a way to create solutions needed to dismantle some of the inequities within your department or within the institution, if you identify that. The third bullet, mutually agree on a clear vision. This is about that vision of excellence that I just talked about how do you use conscious inclusion and being equity-centered in order to embed this in all the operational practices, throughout the department and also throughout the institution as something that's routine, that's ongoing, and an innocent element of its functioning as well. And then the other one I'll emphasize is, how do you prepare for the pushback? Because I'm sure you'll get pushback. But I think the important piece about here, that one of the quotes I really love from Stacey Abrams was, "Don't let setbacks set you back." It's really best to do this collectively. If there's some other champions and some other departments that are willing to jump on the same train that you would like to jump on to become an equity-centered department, then again, that's the best way to deal with any of the pushbacks when you have a collective whole that basically does this, but also to help you anticipate what those pushbacks may be and maybe what some approaches may be. Last, investment does matter. And that's investment by the department, but more importantly by the institution and the leadership as well. And just a few that I'll hit in on. One of the things that I saw at Emory that's happening is some of the departments already have representation and have a formal unit that's addressing DEI issues. So I applaud you wholly, because that symbolism of that is so important, because it sends a message to your community that essential racial equity and racial justice is important to us and it's a priority, and that's critical. The important piece is making sure that those individuals, that you've put them in that position, that you grant them authority and also make some decision-making power and allocating the resources they need to do the work, and not stymie or inhibit them as well. Number two, I think data drives change. We know that in medicine, and it informs policymaking. But when I say data matter, this is a time to really standardize how we collect data, the categories and data collections across departments and within schools as well, to really strengthen the ability to really study ongoing rigorous racial equity audits and monitoring your progress, disaggregating the data to the different groups to kind of see what are some of your policy changes and things that you've done, resonating with those as well. So I'm going to end it now and just summarize really briefly. I know I went through a lot of things, but my hope is just to stimulate some thoughts, stimulate some conversation, even when I leave you today, that I would leave you with as well. So in summary, I think equity-centered medical educators and leaders, who I think you have many in the audience already, have an obligation, I believe, to address these many exclusionary practices and inhibitors that really impact our environment. And we need to commit to eliminating those challenges because we have that power. Secondly, I think, equity-minded, equity-centered medical educators and leaders should also use their power, their voice, that privilege, and commit to making transformative system-based changes to really disrupt the status quo that we're living in and eliminate the inequities that have been embedded, in our policies and processes in our institutions as well, that impact institutional culture. And number three, the investment does matter. Again, if you want really successful outcomes to be achieved. And I think you have the collective power to really change and shape the landscape. This is not somebody else's job. This is us about being able to do this. And again, last but not least, I'll say the AAMC is totally committed to providing the assistance that you may need to achieve that next generation of work. So I want to thank you for listening. If we have time, what I'd love to hear is how do you see what the role of the Department of Medicine and Emory, what role can they play in this next generation of work? But also, how can the Department of Medicine contribute and make the change that's important to help the School of Medicine achieve this next generation of work and get to excellence? So with that, I will stop. Back to you, Dr. Armstrong.
Wendy's fine. Thank you so much for that. There was so much to chew on. I will tell you also that anytime you mention John Lewis to this crowd, since he was our representative from our district for many of us, it warms our heart. I have a question that I wanted to ask you, actually, that came from Dr. Law. You mentioned that sort of two guiding principles, learning from the darkness and promoting transformative change, which I think are both really powerful and really important. And I love that framework. So we have a department that endorses transformative change. However, in such a large group, the definition of transformative can vary, and navigating this is sensitive and can sometimes hamper forward progress. So what recommendations do you have to help large institutions define transformative change and navigating change fast enough to satisfy the diverse group and slow enough to sort of help the institution get there, if you know what I mean?
So we could probably talk a week about this whole thing.
Right.
But just really quickly, I think what's important is something really important that you said at the beginning of this, and that is you don't have to have a single definition for it. Right, because again, what I have found is that transformative change, depending on the context that you're talking about, can have different faces. The body of it, the foundation of it is the same, but the reality is having that flexibility and having the humility of being able to basically utilize it, but also channel it into the things that you're actually working on. And so there's a lot, but there's the foundation of it alone. Transformational change, that came from the business world, right? And it's time for us in medicine, as we're starting to really appreciate some of those outside influencers with regards to that, becomes really important. How do you transmit it to it as well? In our paper, we talk a lot about it and also pointed to some really good resources to begin looking at it as well, too. But I think, it starts with really understanding the basics of it, and then how does it get interpreted for them. Transformational change is always associated with and aligned with actionable items. We can talk till the cows come home. That's my rural piece in me that's in there. So, but the reality is that, really understanding why do you want transformational change to begin with? That's where it starts, right? And what does it look like if we didn't have any inhibitors? If I don't think about finances, if money's not an object and people are not an object, what does it look like? And once you get to that point, and not looking what's the world look like, but what does this particular topic area, subject area look like when we get there, let's say in 1 to 2 years, not 5 years and 10 years, but right now, what would it look like in short term? What would it look like in intermediate term? And then long term, what would it look like? And really be honest or really explicit, but also knowing that may change because of the many distractors we get along the way. So for those of you who recognize the logic model, that's what I'm talking about, is really kind of creating that, but also have that visual, and then work upstream a little bit to ask what resources and what people do I have in order to accomplish this? What are we already doing that speaks to this? And how can I elevate it? Number two, what are some of the things that we're not doing that maybe we want to have, and we should be allocating more of our resources to that instead of getting our resources continually to something that hasn't really made any change, right? Then I think last but not least is we borrowed from, as a physician borrowing from CQI, which was so relevant and so important in our space and our journey. We're using the term of continuous equity improvement along this space as well. But it's very similar because we know this model in medicine, right? From patient safety, et cetera, that essentially this whole idea is start first with that particular issue. You may not, and it's an issue that you are aware of, but also how does the community think about that issue? Do they see it differently? Then come to the table with people and basically, just like I was talking about yesterday about equity-centered advocacy, what you do, use that racial equity framework to basically get to those issues, but really not only just talk about the issue, but what's that potential vision that we have? What does it going to look like really well? And then getting back down into collecting the data that you need as well, assessing that data, but also turning that data and transforming it into really actionable items. And the important part about this, we tend to go to create more programs and initiatives. Some people we talk about programitis, that's a kind of an infectious disease of its own, right? But the reality is that how do we make sure that those actionable items are at the population level, but also at the systems level change? Because that's what, again, our institutions, our departments need. We need that system-based thinking place. And there's difference. We have different leaders, right? There are some leaders that are never going to be transformational leaders, and that's okay. They may be more managers than they're not. They may be more democratic leaders. But there's some unique individuals who have some talents, because it takes different talents to be a transformative leader, that's just relationship oriented, who's a gate opener, not a gatekeeper, as an example, sort of thing, who really kind of understands and has the relationships to basically translate people's visions into actionable items as well. And then somebody who is an influencer to the right key stakeholders that have the power to really make those effective changes as well. So it's a lot of stuff there. It just basically, again, I think transformational leadership is something that we need now. And once you begin having it, you may not need it then, realizing that you'll have to switch to other types of leadership styles. But in order to promote and get the action and be that catalyst, that's why I think transformational leadership is something that we're talking about. In reality, it's a fancy name. We've been doing some of this for a long time when I start thinking about some of the innovations and creativity we've had in medicine.
Well, thank you. Thank you so much for that. I think we are at the hour, so I should draw us to a close, but it's been really fantastic to have you address us today and gave us so much to chew on and to think about strategy, etc. There are some comments in the chat thanking you for this excellent discussion and your leadership and continuing in John Lewis's spirit, the good trouble. So thank you.
Thank you for having me. Thank you so much for having me, Dr. Armstrong. I really appreciate it. And thank you all for all the work that you're doing as well too. And again, AAMC, again, I left my my email in the on the slide, but I'll write it in the chat before I leave. So never hesitate to reach out, because that's where we're there. We're here to assist you in whatever way they can.
Thank you.
Great.
Great.
Screen.
Yeah, why don't you? That looks perfect. All right, why don't we go ahead and get started? I'm delighted to welcome everybody to the Department of Medicine Grand Rounds today, December the 13th. And delighted to introduce our speaker today, who's Dr. Josie. Josie completed his undergraduate degree at the University of Michigan, which warmed my heart. So I hope, Joe, that I can welcome you to the ranks of those of us who live in Georgia but are rooting for Michigan in the upcoming playoff.
That's
game.
right. That's right.
Outstanding. He completed medical school at the University of Toledo College of Medicine, his residency at the University of Colorado School of Medicine, and then his cardiology fellowship, his MSCR training, and a subspecialty fellowship in advanced cardiac and structural imaging here with us at Emory. Dr. C joined the faculty in 2020 as an assistant professor. His clinical practice includes a general cardiology clinic based out of Midtown. He reads cardiac CTs, and that's highly germane to what he's going to talk to us about today, and performs intra-op echocardiography for the structural heart and valve program. His inpatient duties include rounding on the structural cardiology service and rounding at the CCU at both Midtown and EUH. And I can tell you from firsthand knowledge, speaking to the residents, that he is an extremely popular and beloved educator in those roles at this still very early stage in his career. So we're very grateful.
I bribed the residents pretty well, I guess.
I don't think so, actually. I think that was all, spontaneous. So I'm grateful for those efforts, and I'm grateful to you for joining us today, and super excited to hear about really this new forefront of cardiology that I don't know very much about. So I'll let you take over.
Well, great, Wendy. Thank you so much for the introduction, and thank you for inviting me to give this talk. I'll go ahead and get started here. So I don't have any disclosures. Over the next 45 minutes or so, I'll kind of walk you through a brief history of cardiac CT, what the current guidelines state are the indications for cardiac CT, as well as some more novel applications of cardiac CT that we do here at Emory. And there are a few indications that I think are pertinent for even non-cardiologists. I think for internal medicine as a whole, that you may or may not have thought of. And then finally, kind of give you guys an overview of our cardiac CT infrastructure here at Emory. So I'll start with the case. So this is a 48-year-old male, hypertension, obesity, sleep apnea, and a family history of coronary disease who comes into clinic with intermittent chest pain. Now, the chest pain is sometimes exertional, but it's kind of difficult to gauge as his ambulation is limited by chronic back pain and knee pain. But his vitals, his exam, and his EKG are unremarkable in clinic. And so the question is, well, what do you do about working up his chest pain further? So the options are put him on a treadmill, do an exercise treadmill test, a nuclear stress test, a coronary CT, or basically just phone a friend in cardiology. But before I jump into the case, let's first kind of give you a background about cardiac CT. So Sir Godfrey Hounsfield introduced the first commercial scanner back in 1971. Now, what's interesting about Sir Hounsfield is that he worked for a company called Electric and Musical Industries back then. Now, EMI was this giant British conglomerate that not only had this research arm that Dr. Hounsfield worked in, but also they happened to be a record label. And so the most famous band signed under the record label was actually the Beatles. So the story is that the sales of the Beatles records actually helped fund the R&D to create a CT scanner. So there have been many iterations of CT scanners over time. 2004 was a big breakthrough with the creation of the 64-slice CT scanner. And this is really where we started to see coronary CTA come into play. And we actually still have many 64-slice scanners out in clinical practice to this day. I wanted to kind of show you how the images in cardiac CT have kind of evolved over time. So this is a very early picture of what electron beam CT used to look like, followed by a single slice CT, followed by a multi-slice CT. And you can see that the image quality has greatly improved from a 4-slice scanner to a 16-slice scanner to a 64 slice scanner, and then finally to pictures that we are able to generate in this day and age with scanners that are as big as 320 slices. They can capture the entire heart with one rotation. And also scanners that have multiple detector heads, and we can actually acquire pictures much faster and improve our temporal resolution of our images. So what do the guidelines say about cardiac CT? Well, they say a lot about how to use cardiac CT in calcium scores, as well as the evaluation of the coronary arteries. There's much less written about using cardiac CT to understand cardiac structure and morphology. And I think this is an area that I'm particularly interested in, and where I see cardiac CT really kind of evolving into its next iteration. But what I want to spend the next several slides on is how the guidelines talk about using cardiac CT in the evaluation of coronary disease. So as cardiologists, when we are evaluating patients for coronary artery disease, we're essentially thinking about testing in two different buckets. The first bucket is what we call functional testing. What functional testing is that we're essentially assessing for the hemodynamic consequences of progressive obstructive coronary disease. And so if you look at this diagram here on the right, this is kind of the classic diagram that we use in cardiology to kind of depict the ischemic cascade. And you can see here that our various imaging modalities, nuclear imaging, echocardiography, MRI, are really looking at the physiologic consequences of increasing ischemia. And this is kind of the different stages that these imaging tests are useful in. And so when we think about functional testing for ischemia, we're essentially talking, our options are essentially plain old EKG, so putting the patient on a treadmill and seeing how the EKG changes, echocardiography, nuclear, which is SPECT or PET, or MRI. Much more recently, there was a new bucket in the evaluation of coronary disease, and that is actually looking at coronary anatomy directly in what we call the anatomic evaluation of coronary disease. And that's really only done in a non-invasive way by coronary CT. If you look at the kind of our timeline of stress testing in the world, for the last 50 some years, we've essentially been using nuclear cardiology. And so if you look at this timeline, coronary CTA really didn't come into play until the mid or early 2000s. And it really didn't infiltrate into mainstream publications here in the New England Journal of Medicine. And this paper was actually published in late 2008. So it's not surprising that if you look at the volume of cardiac imaging done around the country, that nuclear cardiology, SPECTs and PETs, really have dominated the landscape. And coronary CTA is just a small piece of the pie. And so the next question is, well, if we've been doing nuclear cardiology, nuclear stress tests for 50 some years, why do we need to even think about another modality to evaluate patients with coronary disease? Well, the problem is that there's kind of been this dirty secret in cardiology, and that is we are actually not very good at identifying which patients should really get a diagnostic left heart cath or coronary angiography. Again, and I want to clarify that this is in stable outpatients. Obviously, if someone comes in with a STEMI, it's a completely different situation. But this publication came out in about 2010, I think, and essentially looked at a nationwide sample of 400,000 outpatients who underwent a cardiac cath. And of these patients, the vast majority, 84%, actually had some sort of stress test before they had a heart cath. And what was astonishing to find was that less than 40% of patients were actually found to have a significant stenosis greater than 70% in any of their coronary arteries. And if you break this study down even more, and I bring your attention to this box down here, and patients who came in with typical angina, so with actual symptoms, and had a positive stress test. If you look at this blue grayish bar, a hair over 50% of them were actually found to have obstructive coronary disease on their heart cath. It was essentially a coin flip. And so if a coronary angiography in the cath lab is our gold standard in diagnosing obstructive coronary disease, then why not come up with a non-invasive way of looking at the coronary arteries? So that's where coronary CTA really kind of came into play. And, as I said earlier, over time, our image quality improved dramatically. And so we can obtain pretty nice pictures of the coronary arteries. And this is an example of someone who has essentially a normal coronary artery. This is an example of a patient who has very mild plaque in their coronary artery. This is someone with more moderate plaque in their coronaries. And this is obviously someone who has severe plaque. So studies started to kind of come out about coronary CTA. And you can clearly see how if someone has a little or no coronary disease, that coronary CTA is a fantastic tool of ruling out significant disease. In other words, it had great sensitivity. But the problem with coronary CT is that in patients who have more moderate stenosis, and I would actually increase this range from about 40% to 80%, it was much harder to number one, coronary CTA tended to overestimate stenosis severity. And then number two, if someone has a stenosis of 60%, it's hard to determine whether or not that was actually clinically meaningful, if that was actually severe enough to cause that patient's symptoms. And so because of that, the specificity for obstructive coronary disease was only moderate. And that was kind of the knock on doing coronary CT. And so our American Heart Association, American College of Cardiology guidelines for the evaluation of stable coronary disease come out every 10 years or so. So in 2012, it gave coronary CTA a class 2B recommendation as an imaging modality. In contrast, it gave functional testing, specifically nuclear stress tests, a class 1 indication. And so this was almost a death blow to coronary CTA, because in cardiology, at least, giving anything a class 2B recommendation essentially means there's not enough data to really support it. But since that time, there have been an increasing amount of good publications, robust publications that have studied using coronary CTA in both the acute chest pain population, as well as the stable chest pain population. And initially, a lot of these publications were in more radiology-centric journals or in ER literature, but gradually over time, we had more and more buy-in from cardiologists, and then the trials started getting bigger. The trials started to become published in more general medicine journals, and then you can also see here that our trial acronyms also improved over time. Anyway, coronary CTA essentially slowly became more and more mainstream over time. So in 2019, the Europeans, who are usually a couple of steps ahead of us, they came out with an updated set of guidelines about the evaluation of stable coronary disease, and essentially said that coronary CTA was also a class 1 recommendation. They further said that in patients who had a lower likelihood of having severe disease, in other words, in lower risk patients, that coronary CTA was probably a better test, and that in patients who had a higher probability of having obstructive coronary disease, that some sort of functional stress test was a preferred imaging modality. And the reason is because they thought that coronary CTA was a better rule out test, whereas a functional test was a better rule in test. Finally, just last year, our American Heart Association, American College of Cardiology guidelines were finally updated after 10 years and basically said the same thing. So they said that in patients with stable chest pain, CCTA, or coronary CTA, is now a class 1 recommendation with a level of evidence of A. And what was interesting actually was that they actually said that stress testing, functional stress testing, was also class 1, but actually had a level of evidence of B. And they said this for both patients with stable chest pain and patients coming into the hospital with acute chest pain. So now if you look at kind of the timeline of our guidelines, back in 1999, coronary CTA was actually not even mentioned. In 2012, coronary CTA was given a class 2B recommendation. And then last year, it got upgraded to a class 1. The Europeans actually took it one step further. In the UK, the NICE guidelines, NICE is kind of their version of the NIH. They actually basically said that any person with chest pain that you're worried about coronary disease, cardiac CT is actually the first line test across the board. Now for the next part of the talk, let's go back to some of these cases. I'll show you some interesting cases. So going back to our initial case, this patient actually undergoes a coronary CTA. So this is a pretty standard way that we look at coronary CTA. This is actually a 3D reconstruction of this patient's heart. And then we can actually cut through the tissue and kind of just highlight the coronary tree, the coronary anatomy. And then we can highlight each vessel and look at the vessel one at a time. So this here is this patient's RCA. And you can see I'm basically spinning the RCA around its long axis and looking at the vessel in various different views. And essentially, this is a very normal looking RCA. Here is this middle panel is a 3D reconstruction of this RCA. And I've manipulated this image to basically match up with how we would visualize the RCA in the cath lab. And then this final panel here, this person actually ended up getting a cath, and you'll see why in a minute. But this is this person's RCA on cath, and you can see that this vessel basically is identical to its course on CT. This is this patient's left circumflex vessel, which is also normal. This is this patient's ramus branch, which looked okay as well. And then finally, here is the patient's LAD. And right here, as I'm spinning this around, the proximal LAD, there's a focal stenosis that's pretty tight right here. And so this person was sent to the cath lab, and on cath, I'll wait for this to load again here. I'll pause it here. You can see that there's a focal stenosis here in the prox LAD, which also matches up with the 3D reconstruction of the coronary artery. So this patient actually underwent a lima to his LAD and is now doing fine. Let me show you another case. So this is a 59-year-old female with stable sarcoid, pulmonary sarcoid, hypertension, hyperlipidemia, who's been worked up for a few months because of recurrent shortness of breath and chest tightness, mostly non-exertional. I've had a pretty extensive workup recently that basically showed stable pulmonary function. Also underwent a nuclear stress test a few months ago that was unremarkable. Had a normal EKG, had a normal echocardiogram. And so eventually the provider was like, let's just go ahead and do a coronary CTA because I'm not sure what's driving this patient's symptoms. So if you look at this bottom panel here, I'm spinning around this patient's LAD, and there's clearly a significant stenosis here in the prox LAD. And then if I look at the cross-section of this vessel, as I'm scrolling through the cross-section, I'll rewind this video here, you can see that the vessel lumen essentially disappears and then kind of pops back up again. So this is a patient that we called a 90 to 99% stenosis in their prox LAD. And this is the patient's cath. And you can see that here in the LAD, there is indeed a very tight stenosis that the interventionalist called a 90% stenosis. And this person had a stent that very same day and is now doing fine. Here's a third case, 66-year-old female, unexplained exertional dyspnea. She had an outside hospital, had a normal nuclear stress test as well as a resting echo, but because of ongoing symptoms was referred here for cath. And this is the person's left coronary artery injection and essentially big tortuous vessels, but there wasn't really anything obvious. So then the interventionalist went to try to find the RCA, but then had a hard time finding the RCA. There were a number of cath pictures taken, injections taken, and really they couldn't really find the RCA. So this person was referred for a coronary CTA because they were concerned that either there was an anomalous RCA or that the RCA was occluded, and that's why they couldn't find it. So again, this is the 3D reconstruction of the patient's heart. We'll cut through the myocardial tissue and kind of just highlight the coronary tree. And I'll rewind this here in 1 second because there's something that's very interesting about this case. And that is that this person only has one coronary artery, only has the left coronary artery. And so this left main then branches out into the RCA. So the RCA was indeed anomalous. The LAD, the branches going to the RV are also coming off of the left side, the ramus, and a big circ. And it's a pretty rare coronary anomaly, which was actually the first time that I've seen that live. Next case, 60-year-old male, hypertension, smoker, who had a syncopal episode at work. So EMS was called, the patient was sent to Midtown. Initial troponin and EKG were unremarkable. The patient said that he may or may not had some stuttering chest pain before he passed out. So a CCTA was ordered by the inpatient team. And so here we'll cut through the chest wall to get to the heart, and then we'll kind of cut away the heart tissue to highlight the coronary anatomy. And at least at first glance, it looks like, generally speaking, the coronary anatomy is probably going to be normal. But we'll look at each vessel individually here. And so here is this patient's LAD. And you can see, so here's the left main, here's the LAD, here's the cert coming off over there. But with the LAD, you see some calcified plaque here in the proximal vessel, kind of scattered throughout the mid vessel. More calcified plaque here in the mid to distal vessel. Here are the diagonal branches, which we don't see clearly in this one still frame, but they also had calcified plaque. The circumflex, there was calcified plaque proximally in the mid vessel, and then the RCA had calcified plaque in the proximal vessel, mid vessel, and then more in the distal vessel. But if you look at the actual lumen of this patient's coronaries, the actual lumen looks relatively preserved. So this is a patient who essentially had non-obstructive coronary disease, but had a fairly extensive burden of atherosclerotic plaque. And if you look at his calcium score, he had a calcium score of 1100. If this patient had undergone some sort of functional testing first, like a stress echo, a SPECT, or something like that, that test would have probably been normal because this person doesn't have any obstructive coronary disease, but you would not have appreciated the degree of atherosclerotic plaque he actually has in his heart. And so this is a patient that I would manage very differently now, seeing his coronary anatomy, because I would put this person on the highest dose statin possible, get his blood pressure down, and do everything else necessary to modify his risk. Last case, this is a 67-year-old female with chest pain in clinic. We did a coronary CTA on her. And here, this is her RCA. You see that there's a chunk missing out of the mid RCA right here. And so we call this a 60 to 70% stenosis in her mid RCA. This person was sent to the cath lab. And what was interesting about this case is on cath, this is her mid RCA. It actually doesn't look as bad in the cath lab as it does on her coronary CT. And this is an example of what I mentioned earlier, that coronary CT can overestimate stenosis severity. However, because this looks so much worse than coronary CT, and because it's still technically an intermediate stenosis on cath, the interventionalist went ahead and did what's called an FFR. So what's FFR? FFR stands for fractional flow reserve. It's essentially where the interventionalists, they put a pressure wire down to the coronary across the stenosis, and they're comparing the pressure distal to the stenosis versus the pressure proximal to the stenosis. So if there is a drop in pressure across the stenosis of more than 20%, in other words, if the FFR is less than 0.8, then that suggests that this stenosis is in fact functionally or hemodynamically significant. And this is what the interventionalists will use in patients who have an intermediate stenosis. The reason I bring this up is because we can do something similar now using CT. We can actually get a non-invasive measurement of FFR using CT. And there's a lot of high-level math, high-level physics, and computational flow dynamics that kind of go into this. But essentially, there have been a number of trials that have compared CT-derived FFR with invasive FFR. And the correlation is pretty good. And as you can imagine, that doing CT-FFR or adding CT-FFR on top of regular coronary CT increases your diagnostic accuracy. And so our guidelines that were updated last year also said that in patients who get a coronary CT, if you have an intermediate stenosis, that it's reasonable to go ahead and get a CT-FFR evaluation done, or you could do some sort of follow-up functional test to see if that intermediate stenosis is actually clinically significant. At the time of this patient's coronary CTA, we did not have the ability to do CT-FFR at Emory. But since then, we did get that technology, or not that technology, but we did partner up with a third-party vendor to run this analysis for us. And so as a quality check, we actually sent this patient's coronary CT for FFR analysis. And what it turned out is that that mid-RCA stenosis right here was in fact not functionally significant at a CT-FFR 0.88. So if we had this technology available to us at the time of this patient's coronary CT, we would have run this analysis and probably saved her an invasive procedure. So the next part of my talk, I kind of want to go over a few examples of some non-coronary applications or some more novel applications of cardiac CT that I think are somewhat unique here at Emory. Now, there has been a lot of buy-in from other subspecialties, even within cardiology, about some of these other uses of cardiac CT. But for the purpose of this talk, I do think there are a couple of things that might be relevant for the internists in the audience, either on the wards or in clinic. And so the first thing I wanted to highlight for you guys is that you can actually use cardiac CT to rule out thrombus, in particular left atrial appendage thrombus. So the left atrium and the left atrial appendage is actually a fairly easy structure to visualize using CT. And it's this structure right here. And so if we saw a filling defect in the left atrial appendage, that would be highly concerning for thrombus. And so there have been a number of studies that have compared CT versus TEE for left atrial appendage or clot rule out, either prior to cardioversion or in patients who have had a stroke. And the sensitivity of CT was fantastic. It was 100%, and the specificity was 99%. Now, I do want to caution you and to highlight that these are all observational studies. There is an ongoing randomized controlled trial comparing CT versus TE, but my guess is that it's probably going to be non-inferior. So with that said, TE is still the gold standard for appendage rule out for clot. However, I do think that there's a real utility of cardiac CT in patients if there are any kind of contraindication for TEE. And we've actually been using cardiac CT for this quite extensively, at least at Emory Midtown. And in particular, in patients where it's either difficult to pass the TE probe or you're getting inadequate images, patients who there are any issues with them undergoing anesthesia, and then particularly in the COVID era, patients who are on airborne isolation precautions, and you can't do a TEE, I think a cardiac CT is a great alternative. And then also some of the other kind of routine contraindications for TE, such as patients who have loose teeth, who have esophageal strictures, varices, recent GI bleeding. These are all patients for whom I think it's reasonable to consider cardiac CT. And then finally, the other thing to consider is if you need any additional secondary information. Certainly if you know the patient or you have concerns that the patient has a PFO or an ASD, then maybe TEE is a better imaging modality. But if the patient also has, mildly elevated troponin, or they were having chest pain as well, a CT, you could also take a look at the coronaries and be, two birds, one stone type of deal. One part of cardiac CT is a little bit of show and tell now that I'm very excited about, is that we can actually derive TEE images from our CT's reading software. So I have the ability to actually have a virtual TEE probe that I can manipulate using the software program in the exact same way that I would manipulate the probe in a real live TEE. And here in this picture here, I'm actually using this virtual TEE probe to get the exact appendage views that we would do in a live TEE. And I'll just fast forward this. And if you just kind of remember what this appendage looks like here and here, keep that in mind. This is the patient's actual TEE. It's identical. And so we're actually using this more to help our electrophysiologists plan left atrial appendage occlusion procedures. But I think that's an area of cardiac CT that I'm very interested in. So one other area that I think internists might be interested in, and that's the evaluation of cardiac function using CT. So the other thing with cardiac CT is I can manipulate the images to basically recreate all of the standard transthoracic echo views that we would usually obtain. And so here I'm essentially creating a 4-chamber, a 2-chamber, and a short axis of the heart. And I can play the image, and essentially you can easily tell that this person's LV function is probably normal. And there really isn't any regional wall motion abnormalities. We can also use our software to draw out the endocardial borders. And if we are able to draw out endocardial borders, that means we're able to measure your end diastolic volume, your end systolic volume, and then by definition, are able to calculate a stroke volume and a ejection fraction. And so in this particular case, this person's LVEF was 66%, RVEF of 49%, and we know that cardiac CT functional analysis matches up very well with cardiac MRI. This is something that might be relevant, particularly for those of you, on the wards at Grady, at the VA, or I guess also at the Emory locations as well. Patients who have very difficult echo windows. This is the case of a 70-year-old lady who had a STEMI, was in cardiogenic shock, and this is her transthoracic echo. You can see globally that her LV function probably isn't normal. You see something metal in her heart, and that's what Impella looks like. But I don't think you truly appreciate her LV dimensions, LV function, or any kind of other anatomic abnormalities. So this patient actually ended up getting a cardiac CT. And if I, again, recreate some of those echo windows for this patient, you very quickly notice that this person has a giant inferior wall aneurysm as a complication of her STEMI. You can see it here in the 2-chamber view, and you can see it here in the short axis. And this is, something that we didn't really appreciate on her echocardiogram. And you can also tell, obviously, that her LV function is very abnormal as compared to the last case that I showed you. There are other structural abnormalities that we can pick up on with cardiac CT. This is the patient with an ASD. This is the RV, the LV, the left atrium, and the right atrium. And you see that there's a gap here in the interatrial septum. And you see a flow of contrast actually from the left atrium into the right atrium. So this is a patient with an ASD, and you can also appreciate that both the RV and the RA are both dilated, which makes sense in someone with a left or right shunt. This is a patient with a cardiac mass that we instantly picked up on. In this particular case, this person had a large mass across their pulmonic valve that was actually prolapsing in and out of their pulmonic valve. And speaking of valves, this is what a normal aortic valve looks like, a normal tri-leaflet aortic valve that's opening and closing. And here is the left coronary leaflet, the right coronary leaflet, and the non. And this is, in contrast, someone who has significant aortic stenosis. You can see that this person's non-coronary leaflet is basically fixed, and you can kind of see the calcium at the level of the leaflets as well. This is someone who has a bicuspid aortic valve, and you have to be surprised that, looking at or trying to figure out how many leaflets someone may have an aortic valve actually is not as easy as it may be on echocardiography. This is someone that their echocardiogram was read as having a normal tri-leaflet aortic valve. And in this case, this is someone who has a unicuspid aortic valve. And on this person's transthoracic echo, you couldn't even tell how many leaflets there were. We can also look at prosthetic valves. This is a normal bileaflet mechanical aortic valve opening and closing. And what I think is kind of cool with cardiac CT is on the 3D pictures that we can create, it's actually very easy to kind of isolate any metal objects in the heart. And so this is this same patient's mechanical aortic valve, and you can kind of see how the valve opens and closes in 3D. Our cardiac CT program provides a lot of pre-procedural support for our structural team. When we're planning TAVR procedures, we almost exclusively use cardiac CT to understand the anatomy of the aortic valve and the aortic root, and to basically try different valves and different valve sizes to see which one we think would essentially fit. And then we can assess for transcatheter valve replacement both in the aortic position as well as in the mitral position, and also at the same time assess for any potential periprocedural complications. And then lastly, this is an area of cardiac CT that admittedly we're not using regularly, but I think is going to be a game changer one day, hopefully in the near future. And that is actually fusing our CT images to live X-ray or fluoroscopy in the cath lab to actually guide live cath cases. This is a patient where we took a CT of the abdomen and pelvis and basically fused it to the fluoroscopy in the cath lab. And in this particular case, we marked where in the IVC and where in the aorta it would be safe for the interventionalist to take a wire and poke a hole from the IVC into the aorta in order to bypass significant femoral arterial disease. So the last few minutes, I just want to give you guys an overview of our infrastructure here at Emory. So there is a lot of heterogeneity across our different campuses in terms of readers, in terms of reading software, as well as the actual CT scanners. At Midtown, cardiac CTs are read by cardiologists. At Clifton, it's a mix of cardiology and radiology. At St. Joe's, it's read by cardiology. And then at Grady and the VA, it's read exclusively by radiology. I wanted to kind of show you some of our how our cardiac imaging volume has changed, at least at Midtown. Our cardiac CT scanner went live in April of 2019. And you can see how our volume with cardiac CT in this white line has really kind of accelerated relative to nuclear imaging, at least at Midtown. So with the increased volume of cardiac CT and coronary CT, and with increased interest, we are getting a lot more referrals, both on the inpatient side and on the outpatient side to scan patients, which is fantastic. But at the same time, we are getting a lot of providers who are ordering these scans who, are not quite as familiar with some of the potential contraindications. And with all imaging tests, bad data in is bad data out. And so we try to do our best to maintain our quality. And so there are a few things that I wanted to point out that I think that you guys should know in terms of when you're thinking about ordering a cardiac CT or coronary CT. The first thing is heart rate control. Tachycardia is a killer in terms of imaging quality. That really, it causes these terrible motion artifacts and makes it impossible to look at the coronary artery lumens. And the reason is that the coronary arteries are perpetually moving because they sit in the epicardium and they move with cardiac motion. But what's interesting is that the coronary arteries move the least in early diastole. And the only way, or not the only way, but the best way of increasing your diastolic time is by slowing the heart rate down. And so that's why when you guys order a coronary CT on the inpatient service, one of the cardiology fellows will probably call you and say, hey, can you please give X amount of metoprolol? We really need to get the heart rate down as low as possible. Now, this varies across the campuses. At least at Midtown, our scanner is not as good in terms of patients with faster heart rates. So we really try to get the heart rates down into the 60s. Whereas at St. Joe's and at Clifton, their type of scanner, they can accommodate patients with faster heart rates. And so heart rates I've seen patients getting scanned with heart rates of 80 with pretty decent results. The other thing is we almost always get a calcium score, which is a non-contrast CT scan before we do the contrast injection, just to get a sense of what the patient's calcium score is. This is an example of a patient with a calcium score of almost 2,200, of which 940 is in the LED alone. And this may be hard to see with the glare, but there's a ton of calcium here in the Prox LED. And you can't really see what the actual lumen of the vessel looks like. And that's because calcium causes an artifact called a blooming artifact. And it can obscure the lumen of the vessel and can make the plaque look a lot worse than what it actually is. But we don't have an absolute threshold for when we would say we're not going to scan the patient, because here's an example of a patient with a calcium score of just about 1,000, of which 600 is in the LED, But in this patient, that calcium is kind of more scattered throughout the vessel, and you can clearly see that there is still a healthy tract of contrast through the vessel in someone who probably has non-obstructive coronary disease. And then finally, we will almost always ask you what the patient's weight is. This is an example of a patient with a BMI of 57. And what happens is that we don't get great contrast opacification of the coronary arteries. There's terrible contrast to noise ratio. The scan looks essentially like it's washed out. But again, we don't have a hard threshold or cutoff for when we wouldn't scan a patient. Obviously, this patient's a lot smaller. Her BMI was only 42. But you can clearly see that, at least in this particular case, that we can still get a pretty good look at the coronary vessel. In this case, this person has a very normal coronary artery. So there are a lot of nuances in terms of patient selection for coronary or cardiac CT. And the thing is that at least at Emory Midtown, our fellows screen every single one of our cases. And so we'll walk you through some of these nuances, and we're very involved in making sure that we're able to deliver a diagnostic result for you. So in conclusion, there's, I think, significant growth of cardiac CT over time, and I think there's still incredible growth potential for cardiac CT. Locally, we're seeing an increased volume of coronary CTs ordered, which we're all very happy about. But I wanted to convey, importantly, that cardiac CT is growing to not just be a tool to look at or evaluate patients with chest pain and look at the coronaries. I think there's an important utility of cardiac CT across multiple disciplines in medicine. And so I hope I gave you guys a few ideas of when to potentially order cardiac CT in your own practice. And then there's a few things in the horizon in terms of machine learning and more kind of deep diving into plaque morphology that I think are quite exciting as well. I just wanted to highlight our team at Emory Midtown, who we've worked very hard to keep up with increased volume, as well as at the same time maintaining our CT quality. And with that, happy to take any questions.
All right, my mind is a little bit blown by some of those images. That's it's really extraordinary. Actually, Dr. Bailey here asking in the chat, any risk from a renal standpoint, asked like a good nephrologist.
Yeah, so yeah, great question. Obviously, we have to give some degree of contrast. It really depends on, and this is one of those things where there's some nuances in terms of the indication and some more patient-specific factors. So for a coronary CTA, at least at Midtown, our default contrast volume is 60 to 65 cc's. But that depends on what the patient's body size is. It depends on how good their IV is. It depends on what their GFR is. And so for obviously there are an infinite number of answers to this, but let's say, for instance, they had a GFR of 45 and they were an average sized person, we could probably get away with 55 cc's of contrast. But again, this is why we have, in order to maintain our quality and also for patient safety, we screen every single study that comes across.
Can you contrast that for me? Like, what's the volume of contrast that's used in a cath?
So that's a good question too. It also depends on which year cardiology fellow is doing the cath. But I would say for an experienced interventional cardiologist, and it also depends on if they are just doing a straight up diagnostic cath, that's normal. A normal diagnostic cath, you could probably get away with 10 cc's of contrast. But if you are taking someone to the cath lab with a STEMI and you know that you're gonna have to PCI an artery, or in more advanced cases where they're opening up chronic occlusions, you're talking about 90, 100 cc's of contrast, if not more. Another way to put this in perspective is for a CTPE protocol, for instance, that radiologists will run. I think they're giving around 90 to 100 cc's of contrast. So, but anyway, in the cardiac CT world, we can sometimes give half dose contrast, 40, 50 cc's of contrast, but it depends on what we're looking for, depends on the patient size and some of these other factors.
All right. So now you have a number of questions that are related to what can you see. So
Okay.
can cardiac CT report global longitudinal strain in addition to EF?
I don't think there have been some very early papers that have tried to do that. It's very difficult, and we have not started doing that at Emory, but that's a great question and a great idea, I think, for one of the potential future application.
Okay, then thanks for the information on detecting LAA clots. Any data or experience looking for LAA smoke? And similarly, neurology wants a TE on new stroke patients, but it's hard to get them scheduled. Is it adequate for those indications?
Yeah, so also good questions. With regards to the LAA smoke question, one thing I didn't put in the presentation was that in patients who have slow filling of their appendage, which in echo terms, usually what you'll see is smoke, echo smoke, you'll see some filling defect, or you can see some filling defect in the appendage on CT. We have this special protocol for all clots where we do a second scan. We call it a delayed phase scan, where we literally wait 30 seconds and then we scan the patient again. And the purpose of that is if there is truly slow filling of the appendage, i.e. smoke, that on the repeat scan, after you wait 30 seconds or 45 seconds, that if there truly isn't clot, that the appendage will clear out, that you'll see contrast fill to the tip of the appendage. And so this actually increases the specificity of using cardiac CT to detect clot. With regards to the second question about appendage, where neurology wants TE, but this can take days to get scheduled, weekends, etc. So, again, the first thing to just point out again is that from a guideline standpoint, strictly speaking, TE is still the gold standard. So I do want to caution you about that. If there's not a clear contraindication, I still prefer TE over CT. However, we have admittedly done CTs just from a logistical standpoint if we couldn't get a TE quick enough. So yes, the short answer is yes, we have done something like that before. But with that said, our sites kind of vary on whether or not we offer cardiac CT on the weekends and on holidays and after 5 p.m. It is still technically an outpatient imaging modality, just like regular stress tests are. And so at least at our Emory locations, we wouldn't usually do a cardiac CT after hours or on weekends, except for in very select situations.
All right. And then Dr. Allen asks, and I'm curious about this answer too, have you looked at CCTA for vegetations in the context of endocarditis and the sensitivity specificity? Yeah,
so I think I can't quote the exact numbers for you because this question has been raised by other people as well in the past. I think it will be a very specific study, because if we can see a vegetation, then for sure that person is infected. But however, I don't know if it's a great rule out test, because there are some vegetations that are quite small, and a lot of vegetations also tend to flicker around. And so the temporal resolution of cardiac CT, I don't think, at least at Midtown, is not good enough to capture some of these very small filamentous vegetations. The other thing is sometimes vegetations can grow on leads. And for instance, like a pacemaker lead, right? And pacemaker leads usually will create some sort of metal artifact, and that can actually shadow out any potential vegetation. So to answer your question, I don't know the exact numbers, but I do think that TEE is still the better modality for infective endocarditis. But with that said, I do think that CT is a good complement. So in patients who have, we're also concerned about root abscess or something like that, I think CT can kind of assess for some of these other paravalvular complications.
All right. How about non-calcified plaque? Can you see that?
Yeah. So actually, that case, I think I forget case number 5. I think where I showed you where we overestimated the plaque severity on CT. That patient actually had predominantly non-calcified plaque. And this is why in patients who have acute chest pain, I would caution providers on just strictly ordering a calcium score, because you can miss out on plaque that has not calcified yet. And we have seen many cases of patients who had fairly significant stenosis that was predominantly non-calcified. But again, the clinical context matters. So in patients with acute chest pain and inpatient side of things, I do think if you're going to do some sort of CT, you should do a contrasted CT study.
Clinical context always matters. So can cardiac CT help determine flow impact of serial lesions in one artery, whether serial lesions in a single vessel might benefit from revasc?
You know, that's a good question, and a more nuanced question, which makes sense because it's coming from one of our cardiologists. But you know, I think with FFR, with CT-FFR, you should still be able to, let's say you had multiple lesions from the prox to mid vessel. I think you, just like in the cath lab, I think you should be able to look at the FFR distal to all those lesions. And if that is still significant, then I think, you know, that you would apply it the same way that you would do with invasive FFR.
And a question I have, I get confused about what the indications are for cardiac CT versus cardiac MRI.
So they are, so cardiac MRI uses, well, there are a lot of differences. Cardiac MRI uses a magnet, so there's no radiation. And the type of contrast that MRI uses is also very different. And for most people, we think of cardiac MRI as being safe for the kidneys versus using contrast in cardiac CT. So the imaging modalities and the scanners and everything are completely different. The other thing, though, is from an indication standpoint, looking at the coronary arteries, cardiac CT is superior. Looking at function and morphology, MRI is probably superior.
Okay, yeah, that was the point that I was curious about. Any other questions? We've peppered you with rapid fire here. Anybody can feel free to raise their hand. Apparently not. This is super exciting, and I can't wait to see how many new applications you guys continue to evolve with this. And for a non-invasive technology, I think that's incredibly powerful. So thank you so much, Dr. C. It's been fantastic having you with us today, and I've really enjoyed this.
Thank you very much. I appreciate the opportunity.